Let's talk about bariatric surgery and pregnancy. Background: 30% of maternal pregnant patients is obese in the US. Maternal effects of obesity: diabetes, preeclampsia, higher C-section rate, infections, difficult obtaining regional anesthesia, prolonged operating time, increased blood loss, and increased VTE, less successful VBAC, longer labor course. Fetal or neonatal effects: congenital anomalies, growth abnormalities, miscarriages, and stillbirth. Most common congenital anomalies: neurotube defects, cardiac, facial clefting. Harder to diagnose abnormalities on the ultrasound. Bariatric surgery available for patients with BMI of 40 or 35 with other risk factors. Roux-en-Y is restrictive and malabsorptive. Gastric bending is just restrictive. Effects of surgery on fertility: it does increase fertility rate and may affect OCP effectiveness. Effect of surgery on maternal morbidity and mortality: decreased rates of hypertension, preeclampsia, and also pre and gestational diabetes. A lot of these patients continue to be obese. Late complications of bariatric surgery can occur during pregnancy, such as maternal intestinal obstruction, GI hemorrhage. Effects of fetal mortality and morbidity: macrosomia is decreased after Roux-en-Y. Clinical considerations and recommendations for contraception: non-oral contraception options should be discussed. These patients should wait at least 1 year before conceiving. If less than 1 year, serial monitoring of fetal growth with ultrasound should be considered. Nutritional status: common deficiencies after Roux-en-Y: proteins, iron, B12, folate, vitamin D, calcium. Check labs every trimester: CBC, iron, ferritin, calcium, and vitamin D. 60 grams of protein daily recommendation is recommended regardless of bariatric surgery. No recommendation to increase folic acid intake. Patients should take prenatal vitamin on top of vitamins for surgery. However, vitamin A should be limited, less than 5,000 IU per day due to increased risk for teratogenicity. Special considerations: abdominal pain could be complications of surgery and need to be evaluated. Dumping syndrome: due to sugars in the stomach rapidly empties into the small intestine, leading to fluid shifts. Patient will have abdominal cramping, bloating, nausea, vomiting, diarrhea. Hypoglycemia can occur. These patients may not tolerate glucose tests, so home glucose monitoring for 1 week during 24 to 28 weeks can be done. NSAIDs avoided postpartum due to possible gastric ulcers. For labor and delivery, bariatric surgery is not an indication for C-section.